Today's topic is chest pain. So, how are we going to approach the patient with chest pain? We have to follow the diagnostic model. What can be the probable diagnosis of a patient is coming to you with chest pain? It can be musculoskeletal, psychogenic cause, gastroesophageal reflux disease, and angina. These are common probable diagnoses that come to a mind of a physician. Then there are serious disorders which should not be missed in any case. For example, cardiovascular system, there's acute coronary syndrome, aortic dissection, and pulmonary embolism and myocarditis. There can be causes of like lung cancer and spinal cancers which cause the radiating chest pain. There can be infections like pleuritis, pneumonia, mediastinitis, pericarditis, pneumothorax, esophageal rupture. These are some of the serious disorders. What are the pitfalls? The disorders which often get missed and often ignored can be valvular disorders like mitral valve prolapse, esophageal spasm, biliary colic, herpes zoster causes dermatomal kind of pain, a fractured rib due to chronic and severe cough and or due to trauma, any history of trauma, costochondritis, spinal dysfunction, muscular tear. Then we have seven musculates checklist, which is depression, possible can be the possible cause anemia, which can cause indirect chest pain if it is leading to heart failure, drugs, example cocaine, spinal dysfunction, and what the patient is trying to tell me, like functional disorders, panic attacks, or anxiety. Coming towards red flags, which is the very important point for chest pain. What are the red flags for acute chest pain? We have to look for in a patient. For example, he has a history of dizziness and syncope. There is pain, heaviness in arms and jaws. It signifies angina attack. Then we have thoracic back pain. It can be in aortic dissection, sweating, palpitations, syncope, hemoptysis, dyspnea, pain on inspiration, pillar. And the patient has history of ischemia, diabetes, and hypertension. These are the red flags for acute chest pain. Now, coming towards individual causes of chest pain, we have myocardial ischemia. Myocardial ischemia has a variety of pain, and the pain can be in different sites, which you do not often suspect. For example, umbilicus to the pain can be from umbilicus to jaw, and the pain can be in neck and arms, epigastrium, interscapular lesion. Most of the times, the pain of angina is more in left arm than in right arm. And the best predictor for the pain of myocardial ischemia is that the patient is complaining the pain to be present in both arms. And the patient is describing his pain as the feeling of pressure and heaviness, and he is making a sign of clenched fist. These are some of the points we have to notice. Then coming to it, if a patient is coming to you with chest pain, we are going to suspect if the pain is relieved with rest, that pain is of a stable angina, and if the pain is not relieving, we consider it as acute coronary syndrome. So when we do ECG and the patient has ST elevation on ECG, in acute if the when the pain is not relieving with rest, and on ECG there is ST elevation, it is directly termed as ST elevation MI. And if there is no elevation, we are going to order cardiac markers. If the cardiac markers are positive, it is termed as non-ST elevation MI. And if the cardiac markers are negative, this is termed as unstable angina. Unstable angina is due to transient occlusion, which do not result in the necrosis of myocardium. But if there is prolonged occlusion and it results in necrosis of the myocardial infarction or myocardium, it causes the elevation in cardiac markers. Cardiac markers like troponin and CKMB are released when there is damage of myocardium, right? Coming towards aortic dissection, another differential diagnosis of chest pain. The pain of aortic dissection would be sudden, severe, tearing, and it would be retrosternal, like back pain, and on examination there would be inequality in pulses. And transesophageal echocardiography is the investigation of choice. Then we have pulmonary embolism. The pain of pulmonary embolism, and pulmonary embolism itself can be asymptomatic, and the patient can only present with dyspnea. The pain can be retrosternal. And how can we differentiate it from pulmonary infarction? In pulmonary infarction, the pain is usually less dramatic, the condition is usually less dramatic, and it is usually accompanied by pleuritic chest pain and hemoptysis in pulmonary infarction. While pulmonary embolism usually presents with dyspnea, and the patient has a history of travel or immobilization or surgery. So these can be the history points for pulmonary embolism. Then we have the pain of pleuritis. Pain of the pleuritis is very specific. It is usually localized, it is sharp, and it is aggravated by inspiration. It is the point of differentiation from other chest pain, that it is aggravated by inspiration, sneezing, and coughing. It is the pain of pleuritis, and pleuritis is the inflammation of pleura. So, if the pain is aggravating with inspiration, sneezing, and coughing, MI can be ruled out. Then we have acute pericarditis. Acute pericarditis is most of the time viral. Most common causes of acute pericarditis is viral. Post MI, bacterial infection can also be there. Connective tissue In connective tissue disorders, they can also present with acute pericarditis. Signs can be friction rub, tachycardia, paradoxical pulses, and there are different types of pericarditis. Pleuritic type of pericarditis is most common. Pleuritic type of pain is most common in pericarditis. It is aggravated by cough, inspiration, lying flat, and it is relieved by sitting and leaning forward. So spontaneous, another differential diagnosis of chest pain is spontaneous pneumothorax. If the patient has a history of asthma, emphysema, and other pulmonary disorders, and he has a sudden pleuritic pain and dyspnea, we can suspect spontaneous pneumothorax. Um, then there is esophageal pain. If the chest pain is increases with lying and bending, and especially after meals and at night, this is going to be esophageal pain. If the chest pain is not affected by lying, bending, inspiration on the after meals, or these are not the associations, we are going to suspect myocardial infarction. But if the pain is increasing with lying, bending, and after meals and at night, the pain of myocardial infarction is to be ruled out. In the if there is esophageal rupture, the pain would be sudden, and mostly after the endoscopy procedure. In esophageal spasm, the pain is worse, and it is precipitated by hot and cold food or drink, and it is relieved by nitroglycerin. So the pain of esophageal spasm and the myocardial ischemia and angina can be relieved with nitroglycerin. If their pain is from spine, for example, lower cervical and upper dorsal spine, if there are some lesions and there is some trauma, the pain can be radiating towards chest, and maybe disc prolapse or costovertebral joints. If the costovertebral joints are affected, so the chest pain can be there from radiation. Then we have costochondritis. Costochondritis is the inflammation of the costo is the rib joints, is the inflammation of the rib joints, and it is aggravated by breathing and physical activity, and tenderness would be there. When we are going to suspect that the pain is psychogenic, it is often in the left submemory, but submemory region, but can be anywhere. And the pain is for hours and days, while other pains can be relieved with medicines, and there can be some temporary relief, but in psychogenic there is no relief of chest pain, and the pain is for hours and days. It increases with the stress and tiredness, there's another entity like Tokotsubo cardiomyopathy. It is also aggravated by stress. Psychogenic chest pain and Tokotsubo cardiomyopathy both are aggravated by stress. But in Takotsubo cardiomyopathy, there is a physical change. Like if there is a very stressful situation, there would be catecholamine discharge, a catecholamine surge. And if we do the echo, there would be apical left ventricular ballooning, and it causes acute chest pain and SOB. While in psychogenic chest pain, there would be no physical changes in heart if we do echo. Moving on forward, evolution of ECG changes in MI. Before the MI, there is isovolumetric line, and the P, Q, R, S, and T. This ST line is over. ST segment is over isovolumetric line. This is the isovolumetric line, and the ST segment is over the isovolumetric line. Of the minutes after MI, the ST segment starts to rise above the isovolumetric line, and hours afterwards, there is a peak, and then there is the ST elevation. Some points to note in MI is that there is full thickness infarction. If the full thickness infarction, and it's, typical ECG features would be broad Q wave, more than 1 millimeters of broad Q wave. And broad Q wave is normally present in AVR V1 and V3, and lead 3, and it is considered abnormal if it is present in other leads. And it is these broad Q waves are present in Wolff Parkinson's, White syndrome, ventricular tachycardia, and full thickness MI in other leads, right? Normally they are present in AVR V1 and 3, lead 3. But if they are present, and they would be considered abnormal in other leads, and they are present in these disorders. And there would be ST elevation, and T inversion can be there in full thickness infarction. In subendocardial infarction, Q wave would not be there, right? Transmural infarction, Q wave transmural infarction gets benefit from thrombolytic therapy, while the subendocardial infarction do not get benefit from thrombolytic therapy. So there are cardiac markers. Cardiac markers are troponin I and T, in which troponin I is specific for cardiac muscle, right? Because troponin T can also be raised in aortic dissection and renal impairment. And troponins persist for 5 to 14 days. Then we have creatinine kinase. Creatinine kinase takes 6 to 8 hours to rise, and they return to normal within 48 hours. That's why if there is a chance of reinfarction, we are suspecting reinfarction, we have to check creatinine kinase, because it returns back in 2 days, while the tropes persist for 5 to 14 days. Creatinine kinase CKMB is more than 15% of total CK. It is the sign of myocardial necrosis. CK is also increased in intermuscular injection, by intermuscular injection when the muscle is damaged, while CKMB does not. When we are going to refer the patient, if there is obvious and suspected MI, there are the complications of MI. Post-infarct angina is persistent. The unstable angina is unresponsive and unstable angina, pulmonary embolism or dissecting aneurysm, suspected esophageal gastrointestinal disorder that requires endoscopy for diagnosis. So that pretty much sums up our topic of chest pain.